Today we will be discussing novel insights into the metabolism of phosphate and current insights into its treatment. And I'm happy to welcome Professor Ketteler, with whom I will discuss these issues. Welcome.
Thank you.
First question I would like to bring up to your attention and like to hear your comment on is that when we look at current available evidence on the treatment of hyperphosphatemia, you might summarize current knowledge from clinical trials as indicated in the picture, where on the right we see that if we treat patients with no hyperphosphatemia with either placebo or an intervention, that there appear to be no additional advantage for those who have been treated for it, given the fact that the effect is presumably neutral for those who have the placebo. On the contrary, when we look at people who have hyperphosphatemia, clinical trials usually do not have a placebo arm, which makes it very difficult to actually say if one intervention is beneficial or the other would be dismal. So this is for clinicians an issue. So what would you advise the clinicians to do?
Well, what you point out, it's really a pity that we do not have randomized controlled trials that could have aimed at different phosphate levels, for example, especially in dialysis patients. But I remember the discussions very well that people thought, because of the plausibility that phosphate may cause calcification and so on, it was thought not even being ethical. However, I would say that we have some evidence. It's not the ideal placebo-controlled evidence, but there is one interesting observational trial that could be mentioned here. The acronym is COSMOS, and COSMOS was a prospective observational trial where patients were randomly found. It was non-interventionally interventionally performed, but still it observed over 3 years the current clinical practice of handling mineral and bone disorders in a relatively large European cohort of about 7,000 people. And one of the most recent publications of this trial, and you are aware of this, was published last year. And here the ideal serum phosphate level concerning survival was looked at. And it was identified at 4.4 milligrams per deciliter, which is quite close to the KDIGO guideline recommendations, actually. And what you see here on the left side of this figure is the range where there was no indication of increased mortality. The range was 3.6 to 5.2 milligrams per deciliter. But the more interesting figure is the one on the right side, because patients where the phosphate could be moved through these 3 years of intervention from above 5.2 towards the ideal range, they had a clear survival advantage. Here again, placebo is missing, so some care has to be taken with the interpretation of these results, but still this is not bad evidence for that treatment would move outcomes into the right direction. Another previous publication from the same trial shows, in the essence, that most of the phosphate binders do their work. The only exception here is aluminum. You see below the line that this all means improvements in towards of survival when phosphate binders were given, and this aim was even achieved with the calcium-containing binders. So any binder is better than no binder, no treatment of the condition of hyperphosphatemia, at least in hemodialysis patients. It may be a bit different in patients with CKD, not yet on dialysis, especially when we aim at early treatment.
Yeah, why would that be?
We may have the wrong markers. We may look at the wrong markers here. And the study that was published by Geoff Block, 2012, in patients CKD stages 3B to 4, so a GFR of 45 to 20, in this case, milliliters per minute, with high normal, but not overtly elevated phosphate levels, showed that treatment with phosphate binders and the active treatment group was a combination here of sevelamer, lanthanum, and calcium acetate. It was possible to lower the phosphate levels to some degree, but looking at a surrogate endpoint here on the right side, which is progression of calcification, it shows that it made no difference towards placebo with the calcium-free binders, but there was a progression of calcification with calcium acetate in these earlier stages of CKD. So we must make a difference here, and we must in the future identify the right targets. And I think this is the crucial part.
Yeah. And do you think that the data you present here from Dr. Block also provide a safety signal? So might these interventions to lower phosphate actually also bear some risk?
I think based just on phosphate levels, they show that they are neutral at the most, but especially providing larger doses of calcium in these stages seems to be a danger signal here. Yes, okay. I agree with that.
Okay, thank you very much. So I would like to move on to the next issue I would like to discuss with you, which is the fact that given the assumption that controlling phosphate is good, the question arises, what kind of measure of phosphate do we need? So usually we indicate hyperphosphataemia as the indication for treatment, meaning the concentration in phosphate in the plasma or in the blood. But recently knowledge emerges that some other markers of phosphate homeostasis may be more important. What we see here on the left panel is phosphate concentrations in the normal populations, which are all in the normal range, but still apparently phosphate, when it goes up in the figure on the right, apparently there's some increased risk. If you look at the graph on the right side of this panel, in the upper part you see the phosphate concentration after at least 12 hours fasting, while in the lower part you see the phosphate concentration without fasting. To me, this appears to indicate that it's not the phosphate concentration itself, but the way the subject tries to regulate its phosphate, because the upper part of this panel clearly indicates that it's the phosphate driven by metabolism that seems to be important. And this is also exemplified in the lower part of this figure, where these are data from Dr. Isakova, where you see that FGF23, when it's going up, especially in the lower range, apparently is the best indicator of dismal outcome. So the question arises, what measure of phosphate homeostasis should we use?
Yeah, that's an excellent question. And I would say, I would again take it into two parts. I think that phosphate is a good biomarker, a very good biomarker in the dialysis population. I think this may not be linear, but a very clear indicator of risk once a patient has overt or severe hyperphosphatemia. What we have to understand and learn is the role of phosphate and its or regulatory factors in the pre-dialysis stages. And I would point out a very nice graph published from Miles Wolff a few years ago, which shows the sequence of mineral and bone markers through the disease process, depending on renal function. And what we see here labeled as 1 is that the first event that happens is the rise in FGF23, so the rise in the phosphate regulatory key hormone. This is directly followed by a decline in calcitriol, active vitamin D production. And this, as a consequence of this, PTH, parathyroid hormone, starts to rise. One has to assume here that both FGF23 and PTH, as phosphaturic hormones, follow the aim to keep the phosphate low or normal in these stages of kidney disease. Yes. So they are adaptive. At some point, and this is shown here by number 4, these adaptive mechanisms do not suffice anymore. So we see in the late stages, even prior to dialysis, hyperphosphatemia occurring, and then it all deteriorates on dialysis, as is shown here by the gray bar in the middle. So what we have to understand is it the right time to start interfering with these regulatory systems at the point where we see the first hyperphosphatemia to occur? Should we intervene much earlier? Or should we leave it intervening at the deterioration stage of dialysis? I think the current practice or the current stage is to start treatment, phosphate lowering therapies, implementing in CKD about stage 4 when we see hyperphosphatemia. But what we have to learn about is this steep curve of FGF23 rising, and possibly understand when this adaptive rise becomes maladaptive, becomes even a threat for the patients, because as you know, FGF23 may induce left ventricular hypertrophy, myocardial remodeling, and this would probably be triggered by phosphate load, phosphate exposure. So this is exactly what we have to identify. And going back to the block study I showed with the calcium acetate, in this study, there was a high number of patients with relatively normal FGF23 levels at this moment, so patients with a low risk maybe.
Yes.
So that could have been a reason for that outcome.
Yes. Well, now you make the point that it may at least have a rationale to start early, but we just discussed the fact that we are not so sure if intervening early is actually beneficial. So the question arises, what methods do we need and how should we treat it? Because as you know, we have several treatments available, and maybe we can look at the slide right now, which indeed indicate that there may be a difference in the way how you try to control phosphate. So a current clinically relevant issue is how should we do it? And what you see here is a quite recent study which looked at the effect of calcium-based versus non-calcium-based phosphate binders, and they do indicate, or at least suggest, that there is a difference. So does this imply that in these days the use of calcium-based phosphate binders is obsolete?
Critical question, I think. We now have, especially in the earlier stages of CKD, danger signals, safety signals occurring with the calcium-based binders. Going, for example, to one of the 2 large systematic reviews on the issue, looking at all studies that have compared in the past calcium-based versus calcium-free phosphate binding therapy. Taking together the mortality data, there is a 22 and in another study a 46% survival advantage associated with the calcium-free binders. That is quite something. There were some methodological questions about it, but still I think it's a signal that we have to take. However, we have to think also in a way globally, and as shown in this block trial, there is in the early phases this danger signal supported again, but going to Cosmos in dialysis patients, treating with the calcium-based binders is better than no treatment. And coming from, let's say, a guideline perspective, we have to admit that globally, possibly some of the treatments that are available in the Western world may not be available, let's say, in third world countries.
Yes.
So if there are only calcium-based binders available, we should not object giving them in order to protect the patient at least partially from hyperphosphatemia. What is important here is to restrict the dose, and I think I take this wording from the KDIGO guidelines 2009. I think what we have good evidence for is that at very high doses, the calcium load that is superimposed to the patient may indeed do some harm.
Yes.
And then we could possibly go pragmatically for combination treatments, for example, a basic dose of a calcium-based binder and then addition of a calcium-free. That could be a solution, but maybe we have some other ways to interfere with that as well.
Yeah, so when we look at these Cosmos data you project here, apparently the combination therapy seems to be very effective.
Right. If you look to the right, the combinations with the average levels, maybe even superior to the single agents. However, you see the very wide ranges of standard deviations. So these are smallish groups, and we should not overinterpret that.
And could you please also comment on issues of reimbursement of phosphate binder therapies?
I think that's one of the key issues, of course. And I mean, I'm from Germany. We have an interesting system here because we have a budget for each patient. And we can spend, let's say, on average, relatively much money, but we have to take care who is at risk, at highest risk, and who may be at not so high risk. Just one example, if you, for example, start with a calcium-based binder in a low dose and you get the phosphate down, this may be perfectly fine.
Yes.
But for those patients with previous calcifications, young patients who are on the transplant waiting list, where you really want to protect them for calcifying their vessels, you need these, from my point of view, the calcium-free binders. And in Germany, they are all approved and you can use them. You just have to make a single center division who is more or less prone to receive them.
Yes, yes. Thank you. So I want to proceed to the next issue I would really love to hear your opinion about, which is the fact that in the last decades, controlling phosphate has always been focused on phosphate binder therapy. I think you agree. But recently we have new insights that other issues may be at hand as well. We know, for instance, that if you have a low burden of phosphate from the diet, this will induce an upregulation of phosphate transporters in the gastrointestinal tract. At least we do know that it occurs in animal studies. I think it's reasonable to assume that these mechanisms may also apply in human, which could indicate that for patients who have a low phosphate diet or on phosphate binder therapy, this will lead to an upregulation or a propensity for the gastrointestinal tract to reabsorb any available phosphate. It could also imply that patients who are compliant to treatment, in those days they do not take their medications, have a tremendous uptake of phosphate. This new insight may translate, maybe, and I'm happy to hear what you think about it, into new insights into treatment. And the same holds true for emerging insights that the composition of the diet itself, apart from the total load of phosphate, may be of importance. Since we know that inorganic phosphate, as food additives, has a very high bioavailability, while phosphate coming from plant-derived may be very low. So how would you translate these new insights into the clinic?
Yeah, maybe start with the first part.
Yes.
I think this is emerging. This is therapeutic options for the future. What you said is very important, that if the gut is exposed to less phosphate, seemingly, it tries to quench all the phosphate out of the remaining food sources out, and it does that by two modes of action. One is the sodium phosphate co-transporter NaPi2b, and maybe another transporter that is involved here is a sodium hydrogen 3 transporter. We have compounds that would inhibit or completely block these transporters while they are present. For the first part, nicotinamide is an example. For the next part, tenapanor is an example. For nicotinamide, one phase 3 trial is ongoing but has not yet been finished. So we will learn about this, and I would say the most interesting use is as an add-on therapy, to diet, as an add-on therapy to phosphate binding or phosphate binding therapies. For the second part, yes, the source of the phosphate is potentially crucial. And one is the difference between meat and vegetable sources. And this is just on the slide showing the recent guideline on how to handle hyperphosphatemia by dietary phosphate regimens. And one study was published recently by Sharon Moe's group and shows that patients were treated with phosphate based on meat, phosphate based on vegetable sources. The total phosphate, the measured phosphate content of the diets were equal. But what you can see here is that with the meat products, the phosphate rose a little, and also the FGF23 went up a little, while associated with the vegetable content, both parameters, phosphate and FGF23, dropped. And the reason is probably that, for example, vegetable phosphate source is phytate, and phytate cannot be degraded in the gut. There is no enzyme that cuts this hexaphosphate into single phosphates, and then the molecule is too large to enter the body. So very interesting concept. Maybe even more important are the phosphate additives. And here on the right side, you see results from a study performed by Sherman and Mehta in the US. And let's just look at the bars on the left, pork chops. The gray bar shows the natural phosphate content of a pork chop. And out of this, only about, let's say, 60 to 70% is absorbed. Everything above the gray bar in the orange bar are phosphate additives in processed foods. They are used for increasing shelf life. The food, especially the meat, looks better, more reddish, looks fresher, but it's just the looks. And you can see here that it's twice as much phosphate contained, and out of this additional phosphate, probably 80 to 100% get absorbed. So it's an absolute choice of the processed or unprocessed food, how much phosphate in the end enters the body and should be needed for dietary counseling. Yes. We wrote an article some years ago about this potential health risk, because as you pointed out in one of your slides, Dingra and colleagues showed that even in the normal population, there was an increase associated with higher phosphate levels, and this could be due to these food differences. We are voting for or aiming at labeling, appropriate labeling of food products, that our dietitians can make good counseling based on this, but we are not so far yet in order to get that really on the big plate. However, the EFSA, the European Food and Safety Agency, will take a look at phosphate additives in 2018, 2019, so we'll be excited what happens there. But maybe concerning a guideline, it should possibly more explicitly said that a phosphate source, be it animal, vegetable additives, should be advised to the patient in order to get the patient in the condition to really cope with this.
Yes, and would it be important to raise awareness of this issue in both patients, physicians and dietitians?
Absolutely.
Yeah.
I think it's underestimated, and it's also bagatellized by, of course, some players, because phosphate salts are very capable food processors. They are maybe for a big group of patients and people not so toxic, but at least in patients with CKD or advanced CKD, there is an obvious problem, and we should have the potential to react to that.
Yes, thank you. So in these last years, we've gained a lot of insight into phosphate and how to treat it, but this is so much in discrepancy with what we achieve in clinical practice. So there are so many patients whom we prescribe medications to control phosphate, yet it's so challenging to reach target values. And in this slide, there is one of the potential mechanisms why it might be so difficult, which is adherence to drug prescriptions. And here you see a summary of several studies that looked into psychosocial factors that may be of influence in adherence. But apart from adherence to prescriptions, there may be many more factors involved which limit our ability to control phosphate. Could you state on that, and may this be something we need to address more intensively in the future?
Yeah, I mean, as we all are aware, one of the problems with hyperphosphatemia treatment is that hyperphosphatemia is not painful. It does not change, obviously, the body composition. The patient is completely happy whether he has a phosphate of 5 or 7 millimoles per liter if he's doing well. Yeah. He may even be more happy with a phosphate of 7 when he ate a good German sausage in a big amount before that occurred. So it's difficult to convince the patient to treat that condition. And especially now looking again at the very end stage CKD patient, as shown here, there is good evidence actually that the pill burden is extremely high. And we know about this because these are polymorbid patients. And this publication, for example, showed that an average dialysis patient of this cohort took 19 pills per day, and especially half of that pill burden were the phosphate binders. And the phosphate binders are frequently not very small pills, but the larger ones, they do not taste good or give any immediate benefit. And one can well imagine that if a patient starts to not adhere to the prescriptions, he or she may start with the larger pills, with the more frequently given pills. So we have a problem here, and so I strongly believe that if we can limit the number of daily pills to take, we could reach the patient better, we could better communicate also here. But it's not just that, it's also the patient decision is, from my point of view, very much based on the tolerability of the drug. And there it is good that we have a good armatorium, because one patient tolerates this better than the other one. It's mostly gastrointestinal side effects that may contribute to decision making here. But I think it's also our mission to educate the patient well. What are the consequences of each treatment, and how can we communicate that letting it go, letting hyperphosphatemia go, may have very adverse consequences on the cardiovascular system in the long run. I think this is something we could do, our nurses could do, our dietitians could do, and I think we should strongly focus on that.
Yes, thank you. And do you also think that other sources of phosphate may be of importance as well? Because usually we focus on dietary source of phosphate, but in some patients actually the bone might be the source of phosphate.
Yeah, that's true. We have to, it's always easy to accuse the patient of not taking the pills if the phosphate does not go down. It is our duty as informed clinicians that we of course have to investigate other reasons. And as you say, especially a very low bone turnover, but also a high bone turnover in advanced secondary hyperparathyroidism would or could contribute to resistant hyperphosphatemia. And then we should adjust the concomitant therapies, for example, in hyperparathyroidism to increase the dose of calcium mimetics or vitamin D, or in low bone turnover states even to decrease the active vitamin D treatment. Yes. We always have to be flexible here, and we have to understand that problem as well. That's absolutely true.
Yeah, thank you very much. So thank you for sharing your insights, which I will try to summarize. So first of all, you still think, and I think I agree, that despite the lack of hard clinical evidence, there's still a strong rationale to treat hyperphosphatemia in dialysis patients. You agree, I guess. Next, we know that novel insights into mechanisms of hyperphosphatemia, including increased uptake by the expression of phosphate transporters in the gastrointestinal tract, maybe a future window of opportunity for treatments. And we also discussed on the issue of incompliance and other ways why treatments may fail. Do you want to add something to these conclusions?
It's already pretty fine, I guess. Maybe one point I learned just in the last 4 years, I would say, is that the treatment and approaches towards hyperphosphatemia or phosphate load is probably different in earlier stages of CKD in patients not on dialysis versus patients on dialysis. And while we, I think, understand the situation in patients on dialysis quite well, we have a lack of full understanding of the regulatory and counter-regulatory systems that are active in the pre-dialysis stages. And I could well imagine that in just a few years from now, we would base our treatment decisions in these earlier stages not on phosphate levels at all, but on serum levels of FGF23, maybe on phosphate excretion. We have to take a closer look also at the urine as a regulatory organ for hyperphosphatemia. So I think there is something in addition. And I believe that really the phosphate sources, the dietary interventions could become a much more effective target in the future. And in terms of phosphate lowering by phosphate binding or transport inhibiting therapies, it is of importance to have potent binders, potent transport inhibitors with a low pill load, with a low tablet burden. I think this would also enhance the acceptance towards these treatments by our patients.
Yes. Professor Ketterer, thank you very much.
Thank you, Dr. Vervloot. Thank you so much.